Hello everyone. Today we will be studying about autocoids. So basically, autocoids mean something which will regulate by itself. Okay. In our body also there is some substance which are secreted locally, so that it will increase or decrease the activity of the nearby cells. Okay. So these things or these substances are called as autocoids, which is the self remedy which a cell does for its survival. And these autocoids are mainly divided into amine autocoids, which includes histamine and serotonin, and lipid derivatives, which are prostaglandins and leukotrienes, and peptide derivatives, that is angiotensin and bradykinin, and a few other substances like cytokines are also autocoids, which will produce some self remedy for a cell. So moving on to various agonist and antagonists. So these things, that is histamine related H1 and H2 antagonist, we will basically study in antihistamine chapters, which are very important, and these are clinically used. H1 selective are mainly used for rhinitis, and H2 blockers are mainly used in case of gastritis, acute gastritis, or any acidity condition. And in there are also serotonin agonist and antagonist which are used, and angiotensin blockers, leukotrienes antagonist, kinins, which are bradykinin and calidin, so which are related to bradykinin, and prostaglandins, all are there. But basically in the chapter of autocoids we will be mainly concentrating on serotonin, prostaglandins and glucotrienes. This is kinins are hardly used, but they are also the substance which will cause decrease in the activity of a cell. Okay. And this angiotensin are mainly used as antihypertensives, which you will be studying mainly in cardiovascular system. But these three things is what you will be studying in this chapter. So to begin with the first autocoid, that is serotonin. Serotonin is nothing but 5-hydroxytryptamine, and it is having various physiological activity, and its site, 90% of the serotonin is mainly present in the GIT, in the enterochromaffin cells. Okay. And 8% is present in the blood, in the platelets. This platelets will derive it from the blood, because they do not synthesize its own serotonin. And the rest 2% is present in the CNS, because CNS, this serotonin is, it cannot cross the blood brain barrier. In the CNS, in the nerves, which will secrete serotonin as a neurotransmitter, they synthesize its own serotonin. And this serotonin is synthesized from the amino acid tryptophan. Okay. And is stored as a granule, and it is degraded by MAO enzyme, monoamino oxidase enzyme. So the cell storage is in the granules. It is similar to catecholamines, and this I have already mentioned. This cannot cross blood-brain barrier, and in the CNS neurons they will secrete their own serotonin. So moving on to various agonist and antagonist. So before that we will just see the receptors. So there are four major types of serotonin receptors. Actually there are 7 serotonin receptors. Clinically significant and useful serotonin receptors are 4. Okay, all these 4. And then 5-HT1 is mainly present in the CNS and the cerebrovascular system, and it is used in case of migraine. So they are used as an agonist, that is somatriptan, buspirone, and antagonist are ergotamine. And 5-HT2 subtypes are also available. They are also present in the CNS, smooth muscles and platelets. And agonist is LSD, and antagonist is ketanserin, methylsergide, clozapine, cyproheptadine. 5-HT3, it is present mainly in the CNS area prostrana, that is the vomiting center, and also in the peripheral nervous system and enteric nervous system. Agonist is 2-methyl 5 hydroxytryptamine, Antagonist is ondansetron and granisetron, which is very much useful in chemotherapy. 5-HT4 is present in the hippocampus and enteric nervous system. Agonist is metoclopramide, cisaferide, misaferide, and antagonist is a research drug that is GR113808. Moving on to very important subtypes which are used in the clinical practice per se. 5-HT1A, okay, is what is used in the treatment of anxiety and depression. Okay, these are known to affect mood and behavior. Okay, so that is why they have this clinical use. And 5-HT1D is specific and is used in migraine. Similarly, 5-HT2 is mainly having the role in behavior, and hence it is used. And 5-HT3 is plays a role in vomiting center, that is and it is used for chemotherapy induced vomiting. Antagonists are used for chemotherapy induced vomiting. And 5-HT4 is involved in increasing the GI motility. So agonists are used in treatment of atonia. Uh, Coming to the functions of serotonin in the brain, it is involved. It is involved in pain perception. Okay, sleep wake cycle, that is wakefulness is what is in the function of pineal gland and melatonin. So that is also is mediated by serotonin. And as a neurotransmitter, various behavioral or abnormalities like depression, schizophrenia, obsessive compulsive disorder, there and all, it has some use. That is why SSRI is one of the important class of drugs which is used in case of depression, because in these conditions there is decrease in the serotonin levels in the brain. And as a neuroendocrine regulation, it is also plays an important role. So in these conditions also it is used. uh, Endogenous function. So serotonin is in the CVS, that is by acting through the vascular smooth muscles they cause vasoconstriction, and also heart vasodilation and bradycardia is its action, and they can also cause hypotension. Okay, and in carcinoid tumor, large amount is released which can lead to diarrhea, bronchoconstriction and edema. Okay, tumors. Platelet, the function is platelet aggregation and vasoconstriction. Like histamine, it can also stimulate the perception of pain and itch. Serotonin. So moving on to its antagonist, that is ketanserin, which is 5-HT2A. It inhibits platelet aggregation. Okay, and also it is having additional alpha blocking property, and it is effective as an antihypertensive also. It can be used in Raynaud's disease because of its alpha blocking property. Ritanserin is also another 5-HT2 antagonist. So this also reduces thromboxane function, and it increases the bleeding time. That is, clotting is prevented by inhibiting the platelet aggregation. So moving on to one of the important aspects of serotonin, that is something called as serotonin syndrome. Okay, so which is because of excess release of serotonin. Okay, excessive release of serotonin. Why this happens is when you give two drugs which are acting in the same or acting on different parts of same neurotransmitter. For example, when you are giving an SSRI and adrenergic agonists. Okay, so both of and also when you give SSRI and MAVO inhibitors. Okay, so SSRI will inhibit selective reuptake of this serotonin from the synaptic vesicle, whereas MAVO inhibitors will inhibit the degradation. Okay, both together will end up in increased levels of serotonin in the brain. So what happens is there might be hypertension, hyperreflexia, and tremors, uh, clonus, hyperthermia, diarrhea, and mydriasis. So all these things can happen. This is nothing but serotonin syndrome, which is due to excess or potential release of serotonin, and it is a fatal syndrome because it can increase heart rate, tremors, clonus, all these can happen. Very important. That is why these two drugs are not supposed to be given together. Always you have to take proper history before you prescribe. So one of the important application of this serotonin group of drug is in migraine. So before we see how it is helpful in migraine, we'll see what is migraine. Migraine is a disease which is characterized by severe throbbing unilateral headache. Okay, and it is usually associated with nausea, vomiting, fatigue, which will last for many hours. Okay, and classical migraine is for a brief period, and it is associated with aura, which is a visual disturbances occurring prior to the headache. Okay, usually headache will be of various types, like there is sinus headache. So this is the area where the patient will complain of headache. Okay, in this area. So you cluster headache usually on one particular area. So tension headache will involve whole of these areas, whereas migraine is a unilateral headache like this. So one part will have one part of the brain, or there will be headache for only one side. So what are the triggers of this migraine? So anything can trigger, like hormones, when a woman is having her menstrual cycle, or any hormonal fluctuation during ovulation, it can trigger. So any weather changes, stress, food habits, bright light, sound, heavy sound, diet, some with some chocolates, or and also changes in the altitude, air travel, stress, caffeine, alcohol, beverages, changes in the sleep habit. All these are few triggers which can lead to migraine. So what is the pathology of migraine is? So that we don't know the exact pathology, but various theories have told a few changes which are seen. So the first one is regarding the vasomotor mechanism. That is, in many cases it is seen that there is increase in the magnitude of temporal arterial pulsation during the attack. Okay, and there is vasodilation. So H2 receptor activation, dilation. So this 5-HT2 receptor gets activated, and there is direct dilation of intra and extracranial vessels, and this activation will cause activation of this trigeminal nerve endings in the meninges, and also sensory nerve discharge, leading to headache. Okay, and this sensory nerve will result in the neurogenic inflammation, which will result in the release of C substance P and CGRP. So all these are the substances which are resulting in headache. And also there is release of various other inflammatory mediators, like prostaglandin, kinins, which will cause blood vasodilation, perivascular edema, and which will result in pain. And this pain usually lasts for few hours. There is also abnormal neuronal discharge, and also spreading depression in the brain. which also results in hyperperf- hypoperfusion, which is the reason for aura and pain in the migraine. There are also few sterile neurogenic perivascular edema. So that type migraine is also seen in few patients. So basically it is vasodilation, which is mainly occurring because of some substances which are released like CGRP and substance P, and this is the reason for pain in the migraine headache. So there are different types of migraine depending on the number of attacks and severe hours of pain. So in case of, and it is divided as mild, moderate and severe. In case of mild migraine, so the thrombing attack will be one attack per month, okay, and that this attack will be tolerable and it can be only up to 8 hours, and which there is no incapability of the individual. In case of moderate migraine, there will be one or more attack per month, okay, and this attack will be lasting for uh, 6 to 24 hours. The duration is increased. That the attack will be intense and it will be lasting for 6 to 24 hours. And this will usually be associated with nausea and vomiting and other features of migraine like aura, and this will potentially impair the normal function or routine function of the individual. In case of severe migraine, there will be 2 or more attacks per month with severe throbbing headache, and this headache will last for more than 12 to 48 hours. That is 1 to 2 days it will be there. And this will also be associated with nausea, vomiting, vertigo and other symptoms. So why we have classified migraine is because based on the type of migraine is what is how we have the treatment. In case of mild migraine, it can be managed with simple analgesics like paracetamol and other NSAID group of drugs, with or without antiemetics. Moderate migraine, usually a combination therapy of NSAID and triptans or ergot alkaloids are preferred, okay, with or without antiemetics based on the patient. Whereas in severe migraine, a triptan or ergot alkaloid plus antiemetic and prophylaxis is what is preferred. Prophylaxis of migraine is maybe with few drugs, that is propranolol or other beta blockers, amitriptyline, TCAs, flunarizine or other calcium channel blockers, and anti-epileptics like valproate and topiramate. So how does this acts? NSAID, like aspirin, paracetamol, naproxen and diclofenac. These can be given in case of mild migraine. They act by inhibiting the prostaglandin and kinines which are released in the during the neurogenic inflammation. Okay, these are mainly used in case of migraine without ARA, that is mild migraine. And the side effects with NSAIDs, as we all know, it is GI disturbances and bleeding. So, sumatriptan, which is the drug which is most commonly used in case of migraine, it is 5-HT1D, 1B agonist. Very important these are. They mainly act by blocking the terminal nerve transmission, which will cause, trigeminal nerve transmission, and it causes constriction of dilated extracranial blood vessels, and thus it will suppress the inflammation. So this mechanism is very important. So it is available as subcutaneous formulation, oral, and also nasal spray. Probably more effective than ergotamine for the management of an acute attack. Within 10 to 15 minutes, you will get a relief when you use a nasal spray. It is not recommended in patients who are having coronary vascular disease because it can cause vasospasm. Moving on to the next second best drug, that is ergotamine. Okay, so ergotamine is a drug prior to an attack. During the prodromal symptoms also, that time also if you give, it is less effective as attack progresses. It should be given prior. So they also act by blocking the trigeminal nerve transmission. Also, it can be combined with caffeine for better absorption, and potentially severe long lasting vasoconstriction can also be produced with these drugs. It has poor oral absorption, that is why it is combined with caffeine for better absorption. Vomiting and uterine contractions are its side effects. It is also contraindicated in case of peripheral vascular coronary artery disease and peripheral vascular diseases. Dihydroergotamine is its another form, and this is administered IV mainly, and it may be used appropriately for intractable migraine. Moving on to the beta blockers, they are propranolol, metoprolol, and nadolol. They are mainly used in case of prophylaxis, continuous prophylaxis of migraine attack. So bronchoconstriction, fatigue are its side effects, and it is contraindicated in asthma. Cyproheptadine, it is a low efficacy anti-migraine drug. So, and flunarizine is a cerebroselective calcium channel blocker. They reduce intracellular calcium overload, which occurs due to hypoxia. It can lead to sedation, constipation, and dry mouth. Clonidine is an alpha-2 adrenergic agonist. So they act by reducing the coronary blood flow. Tricyclic antidepressants, like those which will block 5-HT, uh, can be given orally at bedtime. So they have few anticholinergic side effects as well. So for the prophylaxis of migraine, so these are the group of drugs which are available. So the best prophylaxis is mainly produced by propranolol. Apart from this, amitriptyline, which is a tricyclic antidepressant, also is an effective drug, and valproic acid, they are known to decrease the frequency of migraine attack. NSAIDs can be used in case of attack, and also for aborting acute uh, symptoms. Methyl sergide is also known to be effective in 60% of the patients of migraine. It is not effective in acute attack, but it is more effective for preventing an impending attack. So methyl sergide toxicity can lead to retroorbital retroperitoneal fibrosis, subendocrinal fibrosis. Recommended dose is mainly for 3 to 4 week drug holiday every 6 months. So that is it for about migraine. So we are moving on to the next autocoid, which will belong to eicosanoid group. So eicosanoids are substance which will contain 20 carbon atom, okay, and unsaturated fatty acid, it derivative, which is mainly obtained from arachidonic acid in the cell wall. So the principal eicosanoids are prostaglandins, thromboxanes, and leukotrienes. So moving on to prostaglandins, before that we will see the biosynthesis of these group of eicosanoids. So as it is mentioned already, it is mainly obtained from prostaglandins. So in the presence of prostaglandin A2 through arachidonic acid pathway, so which further can be through cyclooxygenase or lipooxygenase. Through lipooxygenase is what is your leukotrienes are produced. Through cyclooxygenase, prostaglandins E1, E2, D2, F2 alpha, and thromboxanes are produced. So these prostanoids were in 1930 was uh, thought to be a substance which is present in the human semen. So that is why they called it as prostanoid. They thought it was obtained from the prostagland, prostate, but later it was seen in many tissues. So that is then they realized and uh, they understood that it is not from the prostate. And these prostanoids will act through the prostanoid receptors. They are G protein coupled receptors, and there are many prostanoid receptors like DP, which is for prostaglandin D2. uh, EP is for prostaglandin uh, E2, and F2 is for PGF2 alpha. IP is for PGI2, and TP for thromboxane A2. So moving on to different actions of cyclooxygenase. So cyclooxygenase are of two types, that is cyclooxygenase 1 and cyclooxygenase 2, that we have already seen. So cyclooxygenase 1 will result in the production of prostaglandin E2, I2 and thromboxane A2. So I2 is involved in endothelial integrity, vascular patency, gastromucosal integrity. E2 is involved in bronchodilation and renal function. Thromboxane A2 will mainly involve in the platelet aggregation, that is platelet function. Uh, that is COX2, cyclooxygenase 2 is mainly inducible, and this is produced during the inflammations only. So the prostaglandins which are produced are E2 and F2 alpha, and also enzyme protease. So these are all involved in the inflammation. So moving on to its uses. So individual prostaglandins are used for various purposes. So prostaglandin, we have seen many prostaglandins. So E1 analog is misoprostol, gemiprost is E1, rioprost is also E1, alprostadil is also prostaglandin E1, enprostol is E2, dinoproston is E2, carboproston is F2 alpha. Latanoprost is an prostaglandin F2 alpha analog. Dinoproston is also F2 analog, and ipoprostol is also I2 analog. So misoprostol is mainly used in case of abortion, postpartum hemorrhage, and PPH, because even is present in the stomach and also in the uterus. Methotrexate is also useful for abortion and PPH. Carboprost is also useful in case of abortion. Like misoprostol, N-prostol is also used in case of peptic ulcer, as it is an ulcer protective. And ipoprostol is used for platelet aggregation and also pulmonary hypertension. Latanoprast, bimatoprast, and travoprast, they are used for glaucoma. And tadalafil and sildenafil, they are also prostaglandins which are used in the tadalafil is used for erectile dysfunction. Sildenafil is also used for erectile dysfunction, but also in case of pulmonary hypertension they have a significant importance. And one more important prostaglandin, that is alprostadil, is used in case of patent ductus arteriosus. So this condition also, it is of very much useful to close the patent duct which is not closed after birth. So leukotrienes are also the substance which are obtained from arachidonic acid metabolism, but they are obtained from lipooxygenase pathway, unlike thromboxanes and prostanoids, which are obtained from cyclooxygenase pathway. So they are mainly present in the lungs, mast cells, platelets, and WBCs. Leuco means something which is white. Trienes means which will have a double bond. Okay. So there are many leukotrienes like LT4A4, which is a precursor which will later help in production of leukotriene B4, C4, D4, E4 and F4. Okay, which are the other derivatives. So C4, D4 and E4 are together called as slow reacting substances. This is very important, commonly asked in MCQs. They are called as slow reacting substances of anaphylaxis. Coming to the actions of leukotrienes are important because they cause vasoconstriction. They increase the vascular permeability leading to edema. Okay, and they also increase airway mucus secretion, and they finally result in they act as a potential bronchial spasmogens. When given subcutaneously, they can cause wheal and flare reactions. Okay, hence they play a role in case of rheumatoid arthritis, psoriasis, and ulcerative colitis. So they are one of the important reason for contributing for asthma, hyperresponsiveness of the bronchial tree. So hence leukotriene antagonists are in clinical use. So examples are xylutine, which is an inhibitor of lipooxygenase. That is, it will inhibit all production of all the leukotrienes. So they are mainly useful in the treatment of asthma and allergic bronchitis and also rhinitis. So montelukast, zafirlukast, all these are leukotriene antagonists, which will block C4 and D4, whereas xylutine will block the production of all the leukotrienes. So here I have mentioned two MCQs. Please go through. Thank you.